Hello everyone, welcome to NExT. I am Dr. Swarab Dikshit, your faculty for surgery. So again we have brought a new important case to this clinical series, and today we will be discussing a very important case. So we have a patient in emergency and it is actually 10:15 of the day, so 10:15 p.m. but yes, excited to teach you people. So that is the level of excitement that I decided to make a video. So I have a 4-year-old girl who has actually fallen from a height. So that is a 20 to 25 feet. Actually what is patient's attendants are telling. So 20 to 25 feet the baby has fallen down and they have been brought to my hospital. So this is a case of head injury and I would like to show a few important things. So if you see, there is a raccoon eye. This is what is classically known as raccoon eye. So this is a raccoon eye on the left side. So basically we know that hematoma is on the left side. This baby, we have cleared everything. This baby is also having the rhinorrhea, is not confirmed, but there was a lot of blood coming out. So we have just given the things for testing. So yes, there was a suspected CSF rhinorrhea from the left side with the raccoon eye. So my question is, what side of the base of the skull fracture if it is? What side it could be? It is anterior 1/3, because anterior 1/3 we have rhinorrhea. And remember, when we talk about middle 1/3, we will look for CSF autoria. Now in this baby, there is nothing known as perimastoidal hematoma bruising is not there. But yes, there is one very important thing. You can see this hematoma, this is bruising. Now whenever you are assessing a head injury patient, the first thing that you need to understand is the GCS of the patient. Now when the patient was brought to us, now this is a 4-year-old baby. So whenever we talk about GCS, we need to take care of 3 components. We need to take care of eye opening, we need to take care of verbal system, we need to take care of the motor system. So eye opening, spontaneous, it's 4. To pain, to command it is 3, to pain it is 2, and no response it is 1. Then verbal system, when we talk about the adults, it is oriented 5, confused 4, inappropriate speech or incomplete sentences, that is 3, 2 is incomprehensible sounds or moans, that is 2, and then no response is 1. Now when we talk about pediatric GCS, what's the difference? If we talk about infant, the baby is cooing, that is what is 5, or the vocabulary is of that particular age. If you see that vocabulary, the age adjustable vocabulary is there oriented, then that is 5. Otherwise the patient is crying, so comfortable cry is one thing, then cry to pain is one thing. So that is how we go for 4, 3, and then moaning and insoluble cries 2, and then 1 is no response. Then we have the same things for motor response, that 6 is oriented, obeys command, then 5 is shows localization of the pain, 4 is withdrawal, 3 is flexion to pain, 2 is extension to pain, and 1 is a cadaveric position. Now when we are talking about this baby, this is having a suspected head injury with the base of the skull fracture. This is what we are suspecting. Now we have already seen the GCS. We have already this patient has been with us for 5-6 hours. Now we have been stabilizing this patient. Now patient is hemodynamically stabilized. The patient developed the convulsions. The patient also had a history of vomiting. Now I will ask the parents, इस बच्चे को उल्टी हुआ था? उल्टी हुआ था तो कैसा उल्टी हुआ था? जोर से उल्टी हुआ था, आगे झटका देके लंबा उल्टी हुआ था कि नॉर्मल सा उल्टी हुआ था? कैसा था? जो फेंक के बाहर फेंक के उल्टी हुआ था ना, जैसा आप लोग क्या बता रहे थे? जब So actually the patients told us that they were having a projectile. They were having a projectile vomiting. हाँ, तो उल्टी फेंक के हुआ था कि नॉर्मल? So that was a projectile vomiting. So projectile vomiting. Then the baby also developed convulsions for which we gave him levetiracetam. So what is this? These are the signs of intracranial hypertension. So what in case of infants or in case of kids, what are the things that you will look for the signs of intracranial hypertension? You will be looking for the eyes. So here you can see the classical sunset eyes. Can you see the sunset eyes? Just focus on this. So there is sunset eye, and this is what is very important. Normally if you see my eyes, they are totally different, and if you see this baby's eye, they are sunset eyes. So this is what is very important sign that we have. Then in kids who are less than 2 years, you will have bulging of fontanelle, But here we have slight, you can say slight hematoma. This is because of the trauma also, but this side you can see it's bulged out now. So bulging fontanelle, diastasis of the sutures and dilated scalp veins are the important signs of intracranial hypertension. So now with this, how should we evaluate? The investigation that we will be going for this patient tomorrow is a CT scan. So NCCT is the gold standard for this, and that will tell you what is the level of injury. But meanwhile, what is the standard of management? The first line is a medical management. We need to elevate the head. So why we need to elevate the head? Because when we are elevating the head, the first thing that we need to understand is that we increase the CSF outflow and blood outflow. This reduces the intracranial outflow, hypertension. Why? Because you know the doctrine of Monroe Kelly says that whenever there is any addition to the skull, there is initial egress of CSF and venous blood, and this is what we are doing. Again, we maintain isothermia, isoventilation. Nowadays, we don't go for hyperventilation and hypothermia. So isoventilation and isothermia is what? The second line is we try for osmotic diuresis, and we have added mannitol to this. If the patient doesn't survive to this management, then we'll go for high dose sedatives where we go for barbiturates or vecuronium. So the aim is to suppress the brain and induce coma. When the brain is in coma, then what happens, students? Multiple spikes of the cranial activity go down. The excess blood which is relieved, that will be actually shunted to the ischemic parts, and then if that also doesn't work, we'll go for an EVD, that is ventriculostomy or external ventricular drainage. So this is how we evaluate and how we manage. I hope you like this small case of intracranial, you can say intracranial hypertension or neurosurgery. So do subscribe to NExT channel, do subscribe to my channel, and keep on following us for more such exciting videos. Thank you.